Good afternoon, but also good evening and good morning to many of us. It is our pleasure to welcome you to the 7th ITM alumni webinar focusing on COVID-19 in Peru, on the interventions, challenges, lessons learned, and the way forward. In the ITM alumni webinars on COVID-19, ITM alumni present their impressions on the current situation of the outbreak in their country and highlight how they are engaged in this global fight against the pandemic. The main aim of this series of webinars is to share experiences, expertise, and good practices within the ITM community of alumni, students, staff, partner institutions, and the wider global health community. Our today's moderator is Dr. Tine Verdonk. Tine graduated as a medical doctor and joined ITM in '98. From 2000 to 2011, she worked as the ITM representative at the Instituto de Medicina Tropical Alexander von Humboldt in Lima, Peru. In 2012, Tine joined the unit of epidemiology and control of tropical diseases in the Department of Public Health at ITM, where she is currently working as a researcher in the Tropical Infectious Disease Group. Tine, please.
Thank you, Charlotte. It's truly a great pleasure to introduce Larissa Otero. Larissa and I first met when she was still a student of medicine. And we started talking about epidemiology of infectious diseases, and we dreamt about how we could contribute to public health. Larissa then came to Antwerp and did the Master of Public Health at ITM. Next, I remember Larissa coming back to Lima, but there was also a year in Uganda with Médecins Sans Frontières. Larissa obtained a PhD degree at the University of Ghent in Belgium on a very rainy day in October 2016. Larissa is now one of our favorite guest lecturers at the Master of Public Health at ITM. She teaches about operational research in the field of tuberculosis control. I assume that over the past years, many of you have met Larissa as a colleague, student, or lecturer. I still enjoy talking to Larissa about epidemiology of infectious diseases, and I'm sure we still dream about how we can contribute to public health. And then there was the Corona crisis. I'm really looking forward to hear how epidemiologists and public health experts are tackling this challenge in Peru. Larissa, you have the floor.
Good morning and good afternoon in Belgium. Thank you for the introduction, Tine. Thank you, Charlotte, and thank you for the invitation to these webinars. I've been watching the previous ones and they have been very useful and informative to me. So I will present the situation in Peru and what we've done. I don't know if I'll present my perspective of some lessons learned by now. This will change, this perspective will change in time, and also the possible way forward that the whole world is learning. So Peru, for those not familiar, is in South America, and we border with Ecuador, Brazil, Bolivia, and Chile. We're by the Pacific coast. It's a 31 million population country, geographically very diverse, with the Amazonian jungle taking a large part of the country. However, it's more sparsely inhabited, the Andean mountains, and then the coast. So these three distinct geographical areas have also something to do with how COVID has been distributed. It's an upper middle income country as per the World Bank classifications. However, 21% still live below the poverty line, which is an important decrease from years ago. However, it's projected also to increase by 10% because of the COVID crisis. It's a deeply unequal country despite our economic progress. And under 5 mortality for the whole country is 14 deaths per 1,000 live birth. But the differences between Lima, the capital, and Huancavelica, for example, one of the poorest regions, which is just next to Lima actually, is very large. Also, a large proportion of the population work informally, 69%, so that's also important for lockdowns, and approximately half of them live on a daily wage. So what was done? In March, symptom screening of people arriving from Europe and the US. Peru, of course, a lot of people traveled to the US, to Spain, to Italy, where the large outbreaks started already in March. And they were receiving information and signing forms, but not more than that. Then on 6 March, we had the first case. On 11 March, schools were closed and social distance recommended with only 13 cases. Of course, social distance was not complied much. There was not so much panic yet. And then on 16 March, there was a very, very strict lockdown. Absolutely everything was closed except essential services. The president began to communicate daily the situation. They took it very seriously. There was an official government webpage, and tracing of first cases and contacts was occurring. A call center was established for people with symptoms, plus a web-based triage system. Molecular tests, some few were done, approximately 500 per day. A COVID command was quickly installed, led by an ex-minister of health, mainly to scale up hospital capacity across the whole system, which is quite complicated. I will explain it during the presentation. There were some rapid response teams composed of a doctor, a lab technician, and a driver to conduct case detection at home, and some quarantine of household contacts mainly. Then in April, there was expansion of testing with the use of serological tests for diagnosis, in addition to the fewer molecular tests. I will explain about this too. Hospital capacity continued expanding a lot. Medical staff, EPP, ventilators were mobilized between regions, which has been hugely challenging. An integrated health information system was established for all the components of the health system, mainly for the COVID response. There's a large isolation center for mild cases and contacts was established in Lima and some few in regions. Rapid response teams increased, and by June, they had done approximately 2,700 household visits, as reported by June, and also some fewer follow-up teams, either by phone or visits, have done around more than 62,000 clinical follow-ups by June too. Primary care clinics partially closed, and they were providing essential services, maternal child care, TB treatment, and until a few weeks ago when they have fully reopened, supporting the community management of COVID. The strict lockdown was full until May, when economical phase one started, and mining, manufacturing, and some services, e-commerce, delivery of restaurants started. In phase two, a bit more, and phase three, most activities, working activities have started with reduced capacity. Schools are still closed, except for those in rural areas. And the lockdown is still strict in 7 regions with high burden. Lima is not included there. So that's what was done, and this is how the curve looks like. This is the 7-day rolling average curve of death, and I'm using this one because I think the best, not optimal, but still the best comparison for the region, while there are differences, of course, on who's being tested, so who has a confirmed death, and how are deaths being defined. So we see the United States with a huge outbreak, Brazil, Mexico, and this is Peru. Then Chile and Colombia. Colombia is actually, the names are overlapped. Colombia is the lower one, which has been increasing in recent days, and this is Colombia, while Chile started very well, then has increased a lot, overlapped with Peru, went over Peru, and is decreasing in recent days. Ecuador, that had a very early and strong outbreak too, has gone down and is increasing. Sorry, this is Ecuador, and this one that was almost always down and has increased slightly is Argentina. Uruguay was not in our wording data, but has done also a great job. So these are the trends of confirmed and suspect COVID death. We consider this to be the best analysis for Peru. This comes from the vital registration system, which has a very good coverage for Lima and partial coverage in regions. However, this has been analyzed also, the number of excess deaths is calculated from here. And up till June, most excess deaths were caused by COVID, either confirmed or suspected. So we consider that measuring confirmed and suspect COVID death from the vital registration system is, among limitations, the best to measure trends in Peru. So we see that after a exponential growth, we arrived at semi-plateau, and it has been going a bit down, not as fast as we would want, and it definitely went way upper than what would have been best. By July, in the last week, we've been having approximately 3,500 confirmed cases per day. Test positivities, approximately 17% among symptomatic tested, both combining serological and molecular tests. So test positivity and both number of tests are not so comparable with other countries because we're one of the few, if not the single one, using serological tests for diagnosis. We are doing around 3,000 to 4,000 molecular tests per day in the last week, an average positivity of molecular tests, which are more targeted probably, of 30%. We have over 11,000 persons hospitalized. This is up to yesterday, over 1,200 on a ventilator, and 145 ICU beds available. However, we have 25 epidemics, one for each of the 25 regions in Peru. Lima, of course, takes the whole country's curve, moves the country's curve because it has 1/3 of the population. 11 million persons live in Lima. It's a huge city. And this is a curve in Lima that has finally started to go down with some, well, in the last 4 days, slight increases, not yet sufficient to interpret them. And then we see, I've chosen some of the regions here in Peru. The large ones, Arequipa is going up. Loreto, where Iquitos, the capital is Iquitos, one of the largest cities in the jungle, very densely populated, and had a very, very bad outbreak that went up very, very fast and has gone down now. The same with Ucayali, also in the jungle. Piura in the coast, north coast, also had a very bad outbreak and has been going down, though is still struggling. And Arequipa in the south, the second largest city in Peru, is going up. La Libertad, also in the coast, in the north coast, is going up, but has reached a plateau recently. Cusco, probably many of you know, one of the main touristic hotspots in Peru, and it's in the Andean, the largest city in the Andes, and hasn't, like in most regions in the Andes, hasn't had bad outbreaks. Cases have been going a bit up in recent days, but nothing compared to cities in the coast and in the jungle. So that's quite striking how COVID has affected less Andean regions. But also the point is the heterogeneity of the epidemic. You know, there's one different curve for each region, and hopefully not many, or next wave can also vary in each region. So what was the lockdown effect on movement with such a strict lockdown? As per Google, most people stayed home. And then this is a paper published by Cesar Munaico and colleagues from the CDC Peru, in which they, the blue dots show the data points. This was the emergency, so the lockdown is here, and this is what was expected, and this is what occurred. So there was an effect in the lockdown. However, as we saw in the previous curves, not as intense as one would have liked, of course. So we consider the curve was partially flattened. And why wasn't it more flattened? Well, movements not captured by Google Mobility nor by the RT could have been fueling transmission, super spreading in hospitals, in public transport, in markets, in banks, in hospitals, in police stations, in workplace. How much intra-household transmission occurred? In Peru, most households are intergenerational, as opposed to Europe and the US There are not so many care homes for the elderly. Most elderly live in the household with their families. And also a lot of people could not safely shelter in place for long. 10% of the population has no running water. 51% of the population doesn't own a fridge, so they cannot buy food for a week. Then the government rapidly implemented a large cash transfer program, a bono, of approximately 220 euros that was expected to last for 2 months to over 5 million households. So it was a massive effort resulting from a good economical management in the recent years. However, implementing it was a huge challenge and only a minority received it on time. So this probably explains why many people still were going out. No. So the main problems in implementations was not having databases that could identify and geolocate all household in needs. So there was some misclassification of eligible household, dead people being eligible, or people that did not need the cash transfer were eligible, and others in need were not. So there was problems identifying this. Then 60% of Peruvians do not have a bank account. So how do you transfer money to them? And then another adverse consequence of this is people congregating in banks and ATMs queuing in the short opening hours allowed as part of the movement restriction. So the lockdown was strict in all sense, and even for banks and ATMs that were providing this cash transfer. So this probably was one of the super spreading locations. Then another unexpected for many event was that over 150,000 persons that were living in Lima for many years migrated back to their regions of origin because they didn't have a job. They couldn't stay here during the lockdown. So they were actually walking toward these regions in the Andes, in the jungle, anywhere. So the government tried to organize this, but it was massively difficult, and test them and quarantine them and quarantine them once reaching the regions. But as you can imagine, this was very, very complicated, and this definitely took COVID to many regions, from Lima to other regions. No? What are our testing capacities? We have very limited access to molecular tests. Despite having some gene expert platforms in the country, we have no access to cartridges. So we're using PCR molecular tests, which are processed at the INS, the National Reference Lab. There's been a slow certification of other 12 labs, which I'm not sure if they are fully operating. So everything is still centralized in Lima, and consider the size of our country, that's of course a problem. The turnaround time is at least 2 to 3 days, and there's plans to expand to 6,000 per day. That's still low. Colombia and Chile are doing 20,000 per day. 2 molecular rapid tests have recently been developed in Peru. One of them, Vanessa Adawi, a former student also of ITM, has been deeply involved in it. They are both undergoing clinical evaluation performance to see the sensitivity and specificity, and hopefully this will help expand capacity. So serological point of care tests were bought, a large amount, over 1 million, and they were included in a diagnostic algorithm. They were validated, the first lot of over 1 million was validated by the National Reference Lab, and a sensitivity of 50% and a specificity of 99% was found. So the specificity was good. The testing strategy was, and still is, that persons meeting the case definition have a serological rapid test. If negative, a molecular test. Of course, following what we know about the virus, you would do it the other way around. But, well, this is due to the scarcity of molecular tests, and because in April, many people were arriving very late, so the serological rapid tests were positive. However, of course, if the strategy keeps working, detecting cases, if you have many serological tests positive among symptomatics, then that's a huge signal that there's no early diagnosis and that we're missing the infectious period. So it can be, I think it's okay to use it in a surveillance system in which isolation, contact tracing, and quarantine start with symptoms, and serology can be used retrospectively to confirm diagnosis. So you don't use a scarce molecular test at the beginning when you're sure or pretty sure the person has COVID and that the person can be isolated, or contact trace and quarantine, and then you confirm retrospectively, then this would be okay. A very good use of serological tests was detecting groups and locations of high risk of transmission. I'm showing here food market vendors in Lima. 26 markets were surveyed by June, over almost 7,000 vendors, and 44% prevalence among them. Very high, of course, among the highest I've seen reported in the world. In regions, it was a bit lower, 19%. Most of the outbreak has been in Lima, and there have been markets with 0% of vendors having antibodies for COVID. In public transport stations, almost 4,000 users have been tested, 27% prevalence. And then a prevalence survey started a week ago. Results must probably be coming soon. It has been a huge effort of the CDC Peru. So this has been an excellent use, and I think will continue to be a very useful use of rapid serological tests. However, the use also expanded to the general population screening, and results are being interpreted for individual care among asymptomatic persons, which is of course a huge problem. Positives are treated as infectious and isolated. So if they don't have symptoms, we don't know if this is an active case or a case that started in March, although it might be, of course, a recent case, but we don't know that. And isolating so many people doesn't really make sense. Negatives are perceived as being free from COVID. No, they were being used to return to work. So person were being tested, and if negative, then you can come to work, but then that doesn't mean anything. You could have COVID in the last week, or you could get it in the next days. And then persons with positive serological tests wanted a confirmation with a better perceived molecular test. But of course, the molecular test was negative because some days had passed already. And then they deeper distrust for the serological test. So this diagnostic problem, interpretation problem, is something that has to be looked at if countries are going to complement serological tests for diagnosis. Also, many brands have been bought and not necessarily all validated, like the first one I showed from the INS. And this is a problem, of course, because the lower the specificity, the more false positive you will have, especially among those with a lower pretest probability. No? We've also had huge implementation challenges to detect early detection of cases, contact tracing, and quarantine of contacts. A huge backlog of persons calling for symptoms. Geolocating of location of household has been very, very difficult. A lot of imprecise addresses. I was already mentioning that we have difficulties identifying households that require the cash transfer, etc. Presumptive TB cases are visited several days after symptoms. It's unclear if they are isolated meanwhile. And timeliness of food packages for isolated households was not also, it has been also challenging to implement. So I wonder how our cascade of care looks like. No, we have the new infections, the new symptomatics, which of course this does not depend on the response, but how many of the new symptomatics call for symptoms, how many of them are diagnosed, how many are isolated, how many comply with 14 days isolation, and the time between these ones. No? These are indicators that are important to look for. The same for contacts. No? How many of the contacts expected are listed, how many are traced, how many quarantine, how many comply with full quarantine. And this is an indicator we haven't seen, not even at the start, and most of the countries in the region, especially Argentina, had been reported in Colombia too, I think, for almost up till now. Now the percentage of cases that were registered in the contact list and the percentage of cases unlinked. Coverage, speed, and compliance of isolation and quarantine, I haven't seen it reported, I think, from not much in other countries, but a very good modeling study from the UK found that these three were the variables that could define the effect of isolation and quarantine. So how prepared were we, and what are the possible way forward? What explains all this that we've seen now? No? Where did we start? We have the lowest health expenditure in the region. Brazil here has the highest. It's in red behind Argentina, Chile, Uruguay, Ecuador, Colombia, Bolivia, Suriname, Paraguay, and Peru is the lowest, absolute lowest in the region. It's true that our GDP has increased in recent years, so it's actually a larger absolute number, but I think it says something that of how much attention was put in health. No? We also have a fragmented health system, which is a huge problem, and this is quite characteristic of Latin America. So the MOH, which manages 55% of the population and is universally accessible, but of course it's not sufficiently funded. Then we have the social security, which is under the Ministry of Labor, which manages around 35% of the population. So these two are the largest ones. And the army and police hospitals on the Ministry of Defense, the Ministry of Interior Affairs, and the private sector. So although the governance is under MOH, fragmentation of the system fuels, of course, inefficiency, duplications, red tapes, plus the system is also decentralized in the 24 regions, which have certain autonomy. This fragmented health system also translates into a fragmented health information system, which is a problem for a pandemic. In green are things that are data that's especially important for COVID. No? So the CDC Peru has collects data on confirmed probable cases and death. We have the National Reference Lab, which has a database for molecular tests, and rapid serological tests, which are most of the ones used, are registered separately. This does not interoperate. In the recently established CCOVID, an integrated system for the whole spectrum of the health system. So this was a great effort in order to have information from the whole sector in a single system. However, it still does not operate with many of the other systems. No? This is the vital registration system, also existing since 2017, and quite high quality with a very good coverage in Lima, and that hopefully can be expanded. And these are the non-health information systems that would be also very useful to interoperate. So the positive that we do have multiple electronic person level databases. We have a very high coverage of unique identifier code, one of the highest in the world. So that brings perfect opportunities for interoperation. Then recently there's been an effort from the government of opening data for COVID cases and death, which is, I think, a great sign of transparency. However, we still have fragmentation, duplications, and no interoperation within the health sector and across sector. Data not always translating into information, so data rich, information poor in many aspects, and information not always translating into decision making. So we have places to start with, but there are still gaps in our health information system. In 2017, the OECD recommended, did an evaluation of the Peru health system and has a whole chapter on the health information system, recommending that we need a viable and sustainable health information system to meet challenges ahead, to adequately measure health system performance, including quality. It gave 5 recommendations, the first being strengthen data governance and accountability, to share data, obliged to share data with stakeholders. So that's something that happens. Data is not shared, not even during a pandemic. And ensure that all schemes of the sector, so of this fragmented sector, contributes to produce nationally representative indicators. Otherwise, the Social Security has their indicators, MOH their indicators, and that's a huge problem to analyze the country as a whole. Hospital capacity, we also had the lowest in the regions with 3 ventilators per 100,000 persons. So this has been one of the great works in the recent month. By 6th June, we have from 200 ICU beds, we have over 1,300. Again, this shows by Social Security, MOH, private, regional governments, and others. And the hospital have been working with approximately 50% of the staff. Doctors and nurses have been doing an incredible job for many, many months already, and working at way above their limits. Our public health capacity, we have a CDC Peru, which conducts surveillance and analysis, and it has nationwide coverage with one epidemiologist in each region. We have primary care clinics conducting maternal child care, TB treatment, promotoras de salud, health promoters, over 60,000 in the country, but most over the age of risk, so they are not actively working in person. We had a cholera outbreak in 1991 that had a strong public health strategy. We've had dengue outbreaks recently, but no recent infectious disease outbreak requiring isolation and contact tracing, as opposed to Asia, of course, as opposed to some African countries that have managed Ebola and that have had experience in this. Our contact investigation experience is probably related to TB. The TB program screens over 60,000 TB close contacts every year. Most of them are household or very close contacts, so rarely we go beyond the household or close contacts, and rarely labor or social contacts are tested and are evaluated. And then the compliance drops a lot in months 2 and month 6. So TB contacts have to be seen at month 0, 2, and 6. So of course, TB doesn't need the speed that COVID requires, but we already see that we're having challenges doing this rapid case and contact isolation. Another important aspect is medical and nursing education in Peru. So we have very few, in general, very few specialists, medical specialists, 201 intensive care specialists in 2018. And again, one of the lower doctors and nurses numbers per thousand population in the district and in the region. And then also the training is more clinically focused, and there's less public health and admin training. I'm not saying doctors and nurses should be training necessarily in administrating health systems, but they are usually the ones administrating health systems, doctors. So, and then there's an issue also with university education in Peru in general, not only with medical and nursing. There's been an expansion of low-cost, low-quality, for-profit universities, which many of them, including medical and nursing. Medical is a profitable career for these for-profit universities because it's a longer career. There's been recent efforts in regulating quality. However, this institution has been constantly harassed by politicians that have conflict of interest with these for-profit universities. However, SUNEDU has had a good job in revoking license of many of these low-quality universities. To give an example, which is not actually an anecdote, Telesup University, which is owned by a quite powerful politician who has currently 11 congressmen in the Congress, had its license revoked last year after 15 years issuing professional titles, including medical students. And this is one of their sites, no? So they built this fake wall to simulate that they had a larger site that would have sufficient rooms for students. So this is how far this regulation of education and informality in Peru can go. Well, we have a democracy, a president that was actually elected as vice president. The president was vacated, and the current president became president a couple of years ago. They've been, I think, the president has a high approval for the management of the pandemic, despite things have not gone as good as everybody would have liked. But I think they took it very seriously. They are trying to do their best. There are 24 regional governors which have autonomy, so leadership should also be placed on them. And we have many, many mayors, one for every district in the country. In Bogotá and Medellin, the two largest cities in Colombia, the pandemic has been mainly, or has had a very, very strong leadership from mayors. We have not seen so much of that in Peru. The Congress is a huge problem. It was closed last year, a new one installed in March, and is still a disaster a bit and not really contributing to leadership and governance during a pandemic. Corruption is endemic in Peru. Many regional governors and mayors have been either sentenced or investigated for corruption in the recent years. And during this month, we've had 653 corruption processes for overpriced food baskets, fake EPP. So this is really incredible, but it's occurring. And then, but this is of course not a characteristic of Peru, and these very relevant references I recommend to everybody. We see that 10 to 25% of global spend on public procurement of health is lost through corruption, through an analysis of Transparency International. So corruption in health is actually the big elephant in the room that nobody tackles, and I think has a lot to do with pandemic preparedness in Peru. This is our main mode of transport for 80% of Lima. So a huge problem. These larger buses, of course, better, more ventilated, though here windows closed, but as you can see, many people wearing masks. That fortunately has been positive in Peru. Most people are wearing masks. We haven't had such a problem with that. Of course, some people not wearing them properly, but in general, most people are using masks. Still not keeping the distance here. And this person, he charges for the tickets. He's called the cobrador, and he goes seat by seat charging for the ticket with his hand. And he pulls passengers shouting which way they are going. So a very high risk of super spreading. And then these smaller buses, the combis, this is a recent picture, no? So how can we control COVID like this? And public transport was already a health problem before, not only for many reasons of the chaotic transport taking hours to commute and all that, but a study from a colleague from Cayetano found a very higher risk of tuberculosis by public transport users, control for income and several other, and household and workplace contact. So this is something that has to be addressed for COVID and for health in general. So some few ideas on public health action that could reduce burden and allow us to cohabit with COVID for I don't know how many months or years, based on what has been done in other countries and a bit on discussions with colleagues and all that. But of course, this can change in time, no? So a coordinated public health strategy. There's still space for coordination, I think, and locally led actions to ensure ensuring public acceptability and cooperation. Of course, after so many months of such a hard time in Peru, the society is tired and they would and poor, and they would like to get over this chapter, but we have a long way to go, and we need to ensure public support of the public health strategy, because it will need to continue in time, and it cannot only be done by the health sector. It needs cooperation from everybody. No? I think we have several strengths in the health information system that should be taken advantage of, improve the coverage and timeliness of the vital registration, which is already good, and I think one of our strongest health information system. The COVID response in the integrated system, but could increase indicators on the public health response. We don't know the coverage, speed, and compliance of case isolation, tracing, and quarantine. And we need to interoperate systems, geolocate households, expand molecular testing, reduce turnaround time, and meanwhile, because we probably won't be able to expand as much as we want, to prioritize molecular tests to those to achieve maximum health, to maximize health benefits, to improve clinical outcomes, reduce spread, to target people that will allow us to reduce spread either to many, so potential super spreaders, or those who could spread to vulnerable population, so that's healthcare workers, for example. And then to strengthen coverage, speed, and of isolation of COVID suspects and quarantine of contacts, we need high quality and trusted call centers. We have many call centers. I'm not sure if we're measuring quality of them, and trust might have failed when calls have been taken very long to answer. Case investigation should start maybe with symptoms from the call and not wait until a rapid response team can reach the household. Visits could be prioritized to those with super spreading potential, and those are unlikely, unable to isolate if these questions are asked during the call. active case finding in high-risk areas. I think the National Reference Lab is about to start this, hopefully with molecular tests in which they can random test individuals and social networks with high risk of spreading. Then to strengthen compliance of isolation and quarantine, more support is needed, financial support, food support, and counseling, because many people just get scared that they are not, they don't know what they're having, and they get scared that they are not being treated. They expect a treatment for this, and they can begin to attend health facility for that, even despite having mild COVID. I think we also need more isolation centers that are also acceptable to the population, basic need covered, medical care, safe, and with communication. Person need to be able to communicate with their family. Early detection of hypoxemia in the community is very important. There's a recent study from Cayetano doctors pointing out how late are patients arriving with hypoxemia to the hospital. Not only that, but also transfer has to be really quick to the health facilities. It's not clear to me how many ambulances we have and if it's sufficient for the demand, and expand telemedicine follow-up. And then finally, one of the most important things I would think is to have very well implemented infection prevention control in healthcare, in transport, in prisons, in markets, in factories, in care homes, and in of these dangerous locations. Clear communication on risk evaluation and mitigation that reaches everybody. That's of course a challenge in a country so diverse and with such deep inequalities as ours. How to sustain safe behavior in time, especially indoors. No? How can you safely isolate at home if you don't have water and sanitation, if you don't live in households that have minimal conditions to live, to have a healthy life? So I think this is a priority, and that should change with this pandemic, hopefully. And then, of course, a system to early detect resurgence, determining optimal timing and duration of lockdowns, what to lock down. I think it's not clear yet as how granular we can go so that there's less impact on the community and on the economy. And of course, continue serological service on high-risk groups and the general population, which I think have been very good. Thanks, and this is it, and I'm open for questions.
Thank you, Larissa, for this overview. Questions are coming in, and I would like to invite the public to keep on asking questions using the Q&A option. Larissa, I'm going to present you a few of these questions. I'll start with questions about, in fact, key features of the epidemic, the epidemiological indicators and measures. Now, if you think of deaths, is there information about case fatality? And are there specific aspects related to case fatality rates in Peru?
No.
Is that something that is monitored?
Yes, but I don't know if, I don't have the data. I think we have two systems, no? The vital registration system, but that we can, it's not operating with the case system, so we cannot do it at the individual level. The CDC does have data on confirmed and suspect cases, but to a minority of them, so no. Case fatality has been analyzed, I think, in some hospitals, but no, we don't, I don't have that data.
Yeah.
No.
Okay, thank you. I think it's challenging in many countries. In the beginning of the epidemic, they talked a lot about case fatality, and now less and less. Then when you think about the deaths as an indicator, do you monitor disability adjusted life years or quality adjusted life years, or just crude counts of deaths?
Crude counts of death.
Yeah. And then there was a question about if you then base the curves on the epidemiological curves on the rapid tests, on serological tests, do you consider that this is reliable data? How do you read the curve if it's based on serology and rapid tests?
Yeah, of course, that's a huge problem. I do think that if serological test results are used, including in the curve for symptomatic persons, so persons that have symptoms and then that meet the case definition for COVID and then have a positive serological test, it's a strong indicative that it can be an active infection. Of course, it might depend on which antibody you find. If it's only IgG, would you consider that an active infection? And it would definitely need to be analyzed with the time of symptom initiation. So I do think a serological test can be used in the epidemic curve as long as they are used among persons meeting the case definition, but definitely not the ones that are screened either in seroprevalence service or not. And these are not included in the official count of in the curve, no? But of course, this does not allow us to compare between regions. And again, if we continue using serological tests for diagnosis, unless we are aware that that means we're diagnosing very late, and this is used retrospectively to confirm diagnosis in cases that have been isolated, I think that's okay. But we need to isolate cases during their infectious period, not when they are serology positive. No? So either we do more molecular tests or we target them to the ones at highest risk, or we isolate people based on symptoms, which I think is the option considering the low availability of molecular tests. But on the other hand, it's also challenging because a lot of people will be isolated without having COVID. They can lose trust in the system, and they can get also anxious and they want a confirmation. So I think it's possible to do symptom-based isolation, but it's also quite challenging.
Yeah, and there are also questions about quality of rapid serological tests in private and public laboratories. Is that feasible to follow that up?
Yeah, so as I mentioned, there's or at least publicly one evaluation of serological tests of the first large lot that the National Reference Lab got. I'm not aware of further validations, and the problem is that the buying options were open for the private sector who has bought massively many tests of unknown quality, unknown specificity. I know the Instituto de Medicina Tropical will start validating some of these tests, but yeah, I definitely think it's a problem because there's no structured system of validating every single test. So we really need to know the performance of each of these tests. Yeah.
And who pays for the test?
In the public system, nobody actually. So both serological and molecular tests are fully free. There's only one lab, a private lab that bought the materials on their own. So they charge for that for private patients. So yeah, for the moment, it's mainly free for everybody, which is of course an advantage, but with 3,000 to 4,000 tests per day, it's still quite limited. I think it's urgent to prioritize testing in those, not in hospitalized patients that you're absolutely sure that have COVID and that management or isolation decisions won't change based on the test. No?
Then there's a series of questions on distribution of infection. For example, is there typical epidemiology for coast, Andes, and Amazon region, or how do you explain the low frequency in the Andes? Is it a matter of time, or do you think it's still going to come? Is there an explanation for that? Also, special risk groups, healthcare workers, for example, like places and populations of risk. Could you comment a bit further on that?
So geographically, yeah, I think it's a bit of a question of time for many regions, no? And it was inevitable to see the overlap of COVID distribution in the first month with tuberculosis distribution in Peru. So exactly the same areas, Lima and Callao, the large metropolitan areas, and even within Lima and Callao, the highest burden districts are the same districts that have higher TB burden. And then the jungle and the cities in the north coast, which also have higher burden of TB than most of the rest of the country. But then, so these were the first places most heavily affected, and then now it has gone south. And the Andes have almost consistently have lower burdens, as occurs also with tuberculosis. There has been hypotheses that high altitude and UV light would reduce risk, and it's definitely possible. And also different social behaviors. People in the jungle and in the coast are more congregate, more social, they are more together than in colder areas in the Andes, where people might be a bit more isolated at home in some areas. So yeah, hopefully this stays like that for the Andean region, which is also one of the poorest regions, together with the jungle. Okay. And among populations, so yeah, well, I showed the prevalence in health, in market vendors and in public transport. I don't have accurate data on health care workers, so I didn't present it, but they are being tested, and hopefully the CDC will show us more accurate burden among them.
Okay, thank you. Then there's a lot of questions on hydrochloroquine and ivermectin. What do you think about that, and what happened in Peru?
Well, that was also a huge mediatic issue. So, well, as we know, there's no evidence for any of the two, and surges fear created a huge problem that Lancet and New England Journal couldn't catch on time. And that, of course, affected many countries, but Peru was one of the most enthusiastic in including it, and it's actually included in the guidelines for under medical supervision indication and considering research conditions, though there's no trial, as far as I'm aware, on it right now. And there was also a huge debate of expert opinion versus evidence opinion. No? So at the end, the MOH recommended it because 60% of the clinical expert group recommended the use of hydroxychloroquine, and 95% recommended the use of ivermectin under medical indication and on following medical criteria. The problem is that we daily get pictures of prescriptions of people that are getting prescriptions on hydroxychloroquine, azithromycin, ivermectin, cortisone, prednisone, everything at the same time, even for mild cases. So that's very, very dangerous. I think, yeah, there was difficulties in differentiating evidence from opinion, but then again, I understand it's a desperate situation and many people just wanted an answer, and many patients are willing to take these pills even if they are not proved. But I do think we need to build more, do more work on the importance of evidence-based, especially pharmacological interventions. No? I think for non-pharmacological interventions, you might not want to wait so much for evidence during a pandemic, and you might, if the risks are low, such as mask wearing, which we now have evidence, no? Then you can be more flexible. But for pharmacological interventions that have adverse events, we need to build up more trust in evidence-based medicine across the society. No?
Yeah. Then there's a lot of questions, obviously, about lockdown, and one angle is which is in Europe we talk a lot about Sweden and what they did. So there was an epidemiologist, I don't know if you've heard of him, Tegnell Anders, who said that well, Sweden did not go in lockdown, and the option was to focus on protecting the elderly and people with comorbidities, and then the idea was that there's not enough evidence that a lockdown is effective, and that lockdowns also cause harm. Now, in Peru, you did go in lockdown, and but in fact, the epidemic still grew. In fact, you went in lockdown very, very early in the course of the epidemic. Could you comment on that?
Yeah, well, I think there's some evidence signaling the lockdowns are needed actually, and I do think it would have been worse without the lockdown. The problem is that as we did it very early, it was first praised as an excellent strategy, and maybe the expectations were way too high, and we expected that then we wouldn't have an outbreak. And even though there were things, of course, that could have been better managed at the start, we will never, I mean, with an 11 million population city such as Lima, we won't manage to do things like Uruguay. Of course, Uruguay has also other structural strengths that we don't have. But so, yeah, I think lockdown was needed. If it was too strict, yes, retrospectively, probably it was too strict from the economical perspective, no? So maybe a more targeted lockdown and not closing all sectors of the economy would have been less harmful. How to know that before things happen, I don't know, no? So yeah, I think lockdowns in more limited resource countries are a huge measure of debate, but not having a lockdown would have been disastrous in Peru, especially in Lima. Again, another thing in the lockdowns, we could also have done more localized lockdowns, which are being done right now. There were many regions with 0 cases or minimal cases, so they didn't need to be in lockdown. Schools in rural areas were under lockdown too, and they don't have access to internet. So yeah, there could have been a less strict lockdown and considering geographic burden. However, I do think it was needed, and I think the Swedish epidemiologist accepts this too, no? That Norway and Finland did better with a lockdown. No?
Okay, and then do you think, you haven't said so much about massive population gatherings, and then there's a question about specific areas, Gamarra. Do you think that it's, I'll read the question after lockdown. Do you think that people can learn to change their behavior and avoid these specific places where many people gather in?
I think it's very difficult. Yeah, Gamarra is this huge commercial place, emporium, where to sell textiles. And yeah, I think it's a difficult area, and that has relatively open early because it gives jobs to a lot of people, and they have very small workshops where they prepare things. So with closed, non-ventilated spaces, which are of course dangerous for transmission. So again, mask wearing is quite good. The adherence is quite good. There's still space to improve it and to sustain it in time and to wear it always well. But yeah, how to change behavior in a country that we don't behave like this. I mean, it's we don't watch distance. We are very social. We speak a lot everywhere. So in Japan, public transport doesn't seem to be such a problem because people are wearing masks and keeping quiet to themselves. That's not what happens in Peru. And then we don't have, so lacking behavior is not maybe the behavior a pandemic needs, a pandemic such as this one needs. So I think it's going to be more difficult, and especially because of the inequities in our country. Now, you cannot ask behavior changes to everybody in the same way when people cannot even isolate safely at home. So I think that's going to be a huge challenge, but well, there's a lot of theory and evidence on how to sustainably change behavior in time. It's not easy, but with clear communication, participation from all actors, trust in authorities, that could help. No? But it's something we're all looking for, no? How to sustain behavior in time, of course.
Okay, thank you. Then there are a few questions on what the issue you raised about information and data and health system organization. Could you summarize what type of research of health system research is needed, and or don't you need research, and do you just want to change data management and information management?
We absolutely need health system research, and I would think this is a weak aspect in Peru. There's a lot of research, medical and science health research being done in Peru, and I would say health system research is one of the least frequent ones. We don't have many health system experts. We do have some, but not as many, and that's something I've learned a lot from the ITM, the second floor of the Department of Public Health. And yes, we definitely think we need more health system research. We're relaunching the Master of Disease Controls we do at Cayetano, at the Institute of Tropical Medicine, aiming to that. No, it's aimed to professionals working in the public sector. And yes, this is an area we have to improve, health system research. There are some few groups also working on health information systems, but I think there's more work to be done. There are some obvious things we don't have to do research. Interoperating databases when you have unique IDs is just an opportunity to be taken. If we had these databases interoperating and giving us access to key indicators on a daily basis, that would be way better than having to construct them with different databases that you cannot interlink. So there are some things that could be done now at pandemic speed, and but I do think we need a long way to work on research on health systems, and not only in Peru, but in the region, because this health system fragmentation, I think it's in the whole Latin American region. However, there are stronger health systems in the region. I mean, Argentina, I think, had 80 beds per population, while hospital beds, while Peru had 16. So there are massive differences in the region, and there are things we could learn from other countries in the region. There are things we could learn from good experiences here in Peru, but we definitely need more health system researchers in Peru.
So if you could copy one element of the pandemic response from other countries in the region, what would you copy? If you could take over one element.
In the region, yeah, that's difficult. I mean, I could say, okay, more tests, like a stronger leadership from many actors, not only the public health sector, but also mayors, like I've seen in Medellin and in Bogota, also in Argentina. So definitely that, scaling up tests and scaling up labs all over the country, that's one. The other, well, public health leadership from not only from public health leaders, but from other actors. Those, I think, would be the two, I would think. I mean, a lot of people are saying, okay, we're not contact tracing and that's the problem. Yeah, but we're not even isolating cases on time. So how can we even start contact tracing if we are reaching cases like a week later, when contacts have already transmitted to a third generation of contacts? So what we actually have to do is isolate cases as close as possible to the infectious period, no? So this early case detection, this public health approach of early case detection, I think something I haven't maybe been clear is that because of our so low hospital capacity, the lowest in the region, or one of the lowest in the region, there was this urgent need to expand ICU beds. I've been following the thread by Wim van Dam and colleagues on discussing the response in limited resource countries, and that the importance of not focusing so much on hospital capacity, but on public health. But I think if you start so low as we started in Peru, there is a need to expand hospital capacities. We could not manage with 200 ICU beds, but not at the cost of disregarding public health strategy. So I do think now we have to really strengthen the public health strategy to isolate cases on time. And I'm not saying it's easy to do, but I think putting more effort in that from all actors is an absolute urgency.
In line with that, I see a question on the recommendation by WHO to do home-based management for COVID patients. Was this considered in Peru, implemented? What are challenges? And in relation with that, there were also some questions on availability of oxygen and use of oxygen at home. What do you think about that?
Yeah, well, home-based management is being done for mild cases. Actually, I would even think of having more centralized isolation centers for people that cannot safely isolate at home or that cannot be safely monitored at home. But home-based management for mild cases, yeah, that's the norm, more or less. And yeah, oxygen capacity that was also discussed in the thread I was mentioning. So yeah, we have a huge problem with oxygen availability and on measuring oxygen at home. No? So the Ministry of Health has, I'm not sure if it's in plans or they already bought them, but a large number of pulse oximeters that should be delivered at home so people can monitor for early hypoxemia at home. But there are other options. You can also teach relatives to measure a respiratory rate per minute as an early sign. So I do think we need to monitor early signs of complications at home, but not only monitor them, but also provide support for transfer, no? Because if there are not sufficient ambulances, if the call centers do not reply, and you already, if you have an oximeter and you already have hypoxemia and you call the call center and you have to call like for 2 hours, or it never replies, and then, so we need to measure to early detection of complication at home with ideally pulse oximeters or finding temporary replacements such as measuring respiratory rate, but we also need to transfer these patients quickly to the hospital so that they can be cared on time. No?
Okay, then there's a question of a different type. Here in Europe, the COVID epidemic came just after, when the flu epidemic was already going down, and that made maybe clinical case definitions more manageable. What do you think about concurrent epidemics? Was that an issue of differential diagnosis with influenza?
I haven't seen any data on that, and there hasn't been much discussion on that either. And we don't, there's an influenza surveillance system, but I don't think as strong as in other countries. I've looked for data on mortality of influenza per year in Peru, and I haven't been able to find it. So yeah. And then we've seen in the vital registration data that mortality for other for respiratory insufficiency has lowered in recent months. So most of, probably some influenza deaths are being counted as suspect COVID for sure. No, so yeah, these numbers are shown on suspect and confirmed COVID death, of course, can be slightly lower because there may have been some overdiagnosis of influenza or other respiratory illnesses. No, but we would not expect it to change it massively, the actual burden of death.
Okay, there are still many questions coming in, but I think we have to round up. And I would like to ask one final question about migrants, migrants incoming and outgoing travelers and migrants. What has been done in Peru? What does the government do, and what could you do? What's your opinion?
Well, yeah, I mentioned about the 167,000 migrants that were living in Lima for many years and wanted to return to region, which was a huge problem because that probably spread COVID to the regions. There's also an issue with Venezuelan migrants because of the tragic situation of Venezuela. Many Venezuelans have come to Peru, I think over 1 million. And it's almost not spoken at in the news. We don't know the situation of these Venezuelan migrants during the COVID epidemic. There's been, I think, more community organization and some parts of the society helping them, but no government. It hasn't been directly addressing the government. I think it's a controversial issue, unfortunately. However, on the other hand, there's been many of the Venezuelan migrants were, of course, professionals, and they were struggling to get to work in their professions in Peru. And because of that, because of the pandemic, this has been eased, and now there are many doctors and nurses from Venezuela working and actually doing a great job in many places. So I think we should protect them more, and we should work more together. Yeah.
Okay, many thanks, Larissa, for all the answers, and many thanks to the public for listening and for all the questions. And sorry for the questions that could not be presented. I now give the word to Charlotte.
Thank you, Tina. Thank you to Larissa as well for sharing her impressions, experiences, and insights on the current situation of the COVID-19 outbreak in Peru. I wanted to thank also to Tina for the interactive moderation of the webinar. Special thanks also to Marianne Pirar for filtering the questions, to Jan Kennis and Guido Verbeek for their technical support. And of course, warm thank you to the participants from around the globe for attending the webinar. We will now go into a summer break, and we will back with the next series of webinars after the summer holidays. And you will be notified by mail on the next webinar. We also thank you for completing the short survey, which will be displayed shortly after. We wish you all the best in the meantime, and most importantly, stay safe and healthy. And thank you to all. Bye-bye.